glitches, but why don't we get started? And today what I'm going to talk about is the role of CMR for assessment of myocardial fibrosis. And so obviously I think most of you have seen this example image that I show here, which basically is actually a study from over 15 years ago looking at a dog model where an infarct was created by ligation of the LAD. And if you look at the left-hand side, you'll see the histopathology. And on the right-hand side, you'll see a corresponding late gadolinium enhancement CMR image. And you'll notice that there's areas of hyperenhancement on the CMR that correspond to the areas of infarction that you see on TTC staining. And in fact, if we take a look at one of these views and blow it up, you can see that the CMR gives you an almost exact match to what you see histopathologically. And in fact, this study demonstrated that whether the MRI was performed 1 day, 3 days, or 8 weeks after ligation and creation of the acute infarction, the size of the MRI hyperenhancement very closely matched the size of the infarct by histology. And pointer?
The pointer part's not working.
Okay.
So if you just use your mouse.
Yeah. I just need it for the pointer, but okay. But that's okay. We can.
Sorry.
I can always point out. And then obviously in humans, several studies have demonstrated the ability of using this late gadolinium enhancement CMR technique to identify the evidence of myocardial infarction. An example on the left-hand side is a patient with an LAD infarct 292 days prior to the MRI imaging. The middle is a patient with an RCA, or left circumflex infarct. And on the right-hand side is a patient with a right coronary artery infarction. And again, in the culprit territory, we see evidence of hyperenhancement present. And in fact, over the last 15 years or so, there's been a wealth of studies that have been done which have really demonstrated, in fact, that the use of this technique can not only be useful to identify the presence of myocardial infarction, both in the acute or the chronic setting, but also can be used to identify the likelihood of improvement in contractile function. In this study, this was looking at patients that were going on for revascularization and showing, in fact, on a segmental basis, that those segments that had no evidence of hyperenhancement had over 80% likelihood of improvement in contractile function after revascularization, whereas on the flip side, segments that showed more than 75% hyperenhancement over here, as you can see in this example, really showed essentially no likelihood of improvement in contractile function. And then beyond the setting of acute coronary disease and chronic coronary disease, there's also data showing, in fact, that the evidence of hyperenhancement by CMR correlates actually with the likelihood of improvement in contractile function in the setting of chronic heart failure in patients that are just getting beta blocker therapy alone. So I think that what we know is the mechanisms by which this works, or what we believe, is due to this phenomenon. Because if you think about it, histopathologically, an acute infarct and a chronic infarct are actually very different. But the underlying mechanism seems to be that if you have normal myocardium, then when you give gadolinium, gadolinium is an extracellular contrast agent. So it's going to distribute to the extracellular space. So in the setting of a normal heart with intact cell membranes, there's really a very small amount of extracellular space, and therefore there's really very little room for gadolinium to distribute. In the setting of an acute infarction, what you have again is you have ruptured cell membranes, and as a result, there's an increase in volume of distribution of the gadolinium. So within any given pixel, in an acute infarct, there's more gadolinium that's present. And then again, the principle by which this hyperenhancement works on CMR is the fact that gadolinium causes T1 shortening and therefore leads to hyperenhancement or high signal when we do T1 weighted imaging. And then
intracellular there in that middle?
Yes, because right.
Extracellular?
No, it's intracellular because there's ruptured cell membranes. So in the setting of acute infarct, those cell membranes no longer are able to keep the gadolinium out, and therefore it's able to enter into the cell. And so therefore, for any given volume, there's more gadolinium that sits within any given voxel. And then the same in the setting of chronic scar, where you have more of a loose collagen matrix, again, you've got an increase in the extracellular space and therefore more volume of distribution of gadolinium, and therefore you see high signal in the setting of chronic scar as well. So although very different histopathologically, the manifestation of this by CMR is essentially equivalent. And so really, that's why I think the unifying mechanism by which we get hyperenhancement on CMR is whenever there is essentially a reduction in the amount of viable myocytes within any given pixel, that then leads to hyperenhancement, whether that be due to acute infarct or due to chronic infarct with collagen replacement. Now, a couple of things that I want to point out, and I think it's really the ability of this late gadolinium enhancement MRI that's made us realize that when we think about myocardial viability and fibrosis, some of the initial concepts we had, we may need to modulate those a little bit. And so this was a publication from a few years ago where we looked at the concept of, is knowing how much viable myocardium there is in and of itself sufficient? And what we're postulating here is that just simply knowing how much is alive or how much viability there is in and of itself may not be sufficient. And the reason for that is if I show you two example cases, so patient A on the top, patient B on the bottom, both these patients, if we look at the cine MRI images, you can see the wall is thin, right? There's a diastolic as well as a systolic frame. You can see both the anterior wall in both patients does not contract, and the anterior wall is also thinned out. It's probably about 4 to 5 millimeters in thickness. And in fact, in this person on the bottom, the wall may be thinner than the person on the top, right? Now, if you look at the size of the black area in both of these two example cases, the viable, because remember again, with this technique, black or viable myocardium would show up as black, whereas infarcted or scarred myocardium would show up as bright. And you can see that in both patients, the amount of the black is equivalent. But in the patient on the bottom, the amount of hyperenhancement or scar is actually much less than the patient on the top. And why is this important? Because depending upon how we quantify this patient, if we just simply look at the amount of viability, we would say that both of these patients have equivalent amount of viable myocardium within the anterior wall. But on the flip side, if we look at really compare the amount of scar to the amount of viable myocardium, we would say there's a big difference here. Patient on the bottom actually has very little scar. The patient on the top here, on the other hand, has a significant amount of that wall demonstrating hyperenhancement or scar. And in fact, these two individuals, when they went on for revascularization, you can see the individual on the top showed no improvement in contractility. The individual on the bottom, on the other hand, you can see the wall thickness actually increased, as did the thickening of the wall post-revascularization. So I'll come back to this principle in a second. But there's one other concept that I want to bring out to you as well, which is the idea that the amount of viability within any given heart actually varies depending upon what part of the heart you look at. And to bring this concept, what we did is actually scan two patients. The top is a normal volunteer, and the bottom is a patient who'd had a prior subendocardial MI. And if we go through, and again, this is the delayed enhancement MRI technique. And if you go through and actually contour the epicardium and the endocardium for both patients, what do you notice? If I show you this first patient on the top here, which is just a normal volunteer, not a patient, and I actually display this out for you in a linear fashion, you can see that the amount of myocardium, of viable myocardium, is actually variable. Now, let's look at the second case, which is a patient with an infarct, with evidence of fibrosis here in the inferior wall. And again, if I trace the epicardium and the endocardium on my late gadolinium enhancement CMR, and I open this up for you, and again, the red here, the red arrows represent areas, or represent where the arrow is along the inferior wall. I would submit to you, if I just showed you this and this, I think we'd have a hard time being able to say if there's an infarct present or not. The idea is that there's variability in the amount of viable myocardium that's present. And so if you only are imaging viability alone, that's not sufficient to give you the complete picture. It's the ability to actually image both viable myocardium as well as scar that I think CMR offers, which I think is unique. And we'll talk about where this may be helpful. And I think some of the areas is one of the things we looked at was in that first example where I showed you where you've got wall thinning. So the kind of the traditional thinking had been that if you have significant wall thinning, then by a priori there can't be significant viability. Then this area must be infarcted and fibrosed. And so I'll show you one example case here, and this is a patient who, if we look at the left-hand, if we look at the septum here, I think most of us would say there's a pretty large area of pretty significant wall thinning. And if we look at the late enhancement CMR, we see an area of transmural hyperenhancement here in this person's septum. So that thinned area looks like it's transmurally infarcted, so extensive scarring as well. On the flip side, I'll show you another example case, and here's another case who has wall thinning that's extensive all along the anterior wall and apex. But when we look at the late gadolinium enhancement CMR, and especially if I take that two-chamber view and blow it up for you, this is the case I showed you before, you can see that the amount of hyperenhancement or the amount of scarring is actually very little. So despite the fact that this wall is very thin, and therefore the amount of black viable myocardium is limited, there's even less in the way of myocardial scarring in this wall. And this person, after revascularization, they had an EF at 30% at baseline after cabbage with a Lima to LED. Now all of a sudden you've got an EF that's improved to 50%. Look at the anterior wall. Look at the thickness of the anterior wall. It's gone from 4 millimeters now to normal thickness, about 10 millimeters. And you can see contractility has gone from really no thickening to almost negative thickening to now positive thickening. So there's actually contractility now in the anterior wall as well. And you can see the EF has gone from 30% to 50%. So when we looked at this in a large cohort of patients, so there were about 200 patients that we looked at that had left ventricular wall thinning. And we're talking about not just a small little area, but a large area of wall thinning defined as more than 5% of the left ventricle. What we found, in fact, was that there is a relationship between the amount of scarring within the thinned area and the change in contractility that happened after revascularization. And you can see that there's this relationship right here that as you had more and more scarring in the thin wall, obviously there's no change in systolic wall thickening after revascularization. But on the flip side, if you look at this group right here, those people who had less than 50% scarring in a thin wall, you actually still see a significant improvement in regional systolic wall thickening after revascularization, whereas obviously those with more than 50% scar in the thin wall, you see no significant change in wall thickening. And then furthermore, when you actually just looked at thickness of the wall, what you find, in fact, is that those patients who had a lot of scarring in the thin wall, obviously the wall thickness didn't change, whereas for those patients who had a limited amount of scarring in the thinned area, that thinned area actually increased in wall thickness, so the wall actually plumped up. So I think that what the MRI really suggested or provided us with an insight, which is that wall thinning itself may not be an irreversible phenomenon. It actually may be reversible. And that CMR is able to identify these patients. Now, what was the prevalence of this? So this phenomenon we found in this cohort of thin walls but having limited amount of scarring occurred in about 18% of patients in this cohort. So it's about 1 in 5 patients that you come across who have wall thinning, who by CMR you actually may demonstrate that there's a limited amount of scarring present despite the fact that there's wall thinning. So I think from the standpoint of assessment of regional fibrosis, what CMR I think offers is the unique ability to image both viable as well as non-viable or scarred myocardium. And I think really it's the only technique that's able to do that. Obviously it's able to do so with a very high spatial resolution and a high contrast to noise and no limitation as far as body habitus. And therefore I think in the arena of late gadolinium enhancement, we use this term bright as dead. So areas that are bright represent areas of irreversibly injured myocardium, and areas that are black represent areas of viable myocardium. Now, using this technique over the last 15 years or so, it's been applied to a variety of different conditions. And what I want to touch on here is one specific group that we looked at, or that we're in the process of finishing looking at, and this is patients with mitral valve prolapse. And you know, what prompted us to look at this was, interestingly, when we imaged these patients, a lot of these patients tended to be patients that were relatively younger, without a lot of other risk factors, yet frequently you find this fibrosis here in the infralateral wall. And so that's what prompted us to say, let's take a close look at these patients with mitral valve prolapse. Now what's interesting is if you look at morphologically, you know, I've got a normal example on the left-hand side, and then I've got a patient with prolapse on the right-hand side. And you'll notice that there's a couple of kind of unusual findings in these prolapse patients just from a standpoint of morphology and function, which is that they tend to have kind of a thinning in this kind of mid to basal infralateral wall. And look at the papillary muscle, right? Whereas in a normal patient, what does the papillary muscle normally do? It actually descends down. In patients with mitral valve prolapse, on the other hand, looks like this papillary muscle is actually being tugged or pulled up. So there's a large amount of stress or strain in this area right here. And so this may explain the mechanism by which we see fibrosis in this specific location. Now the question is, how often does this happen? And I'll skip past this here. So what we wanted to try to find out is, how often does this happen, and is the presence of this fibrosis, again, these are small areas, is this associated with adverse outcome? All right, because if you look at the literature with regard to mitral valve prolapse, you know, it's kind of waxed and waned, you know, as to is there an increased arrhythmic risk in these patients or isn't there? And I think, you know, if you look at the literature over the last 20, 30 years, I think it's, you know, there's some studies that suggest there is, and there's some that suggest maybe there isn't. And so we did for this analysis, and this was one of our former fellows that worked on this, is we said, let's look at patients that we imaged who are coming in for either assessment of mitral valve disease. Okay, we wanted to exclude confounding causes of myocardial fibrosis or late gadolinium enhancement. So secondary MR we excluded. Therefore, people with the EF less than 50% we excluded from this analysis. People with a history of MI, prior revascularization, if there had been any abnormal stress test. People with greater than mild LVH, people with a suspicion for cardiomyopathy, myocarditis, infiltrative disorder, sarcoid, amyloid, anything like that, or people who have other valvular disease other than the mitral valve disease, and obviously people with prior cardiac surgery, because we know that that can also lead to the development of myocardial fibrosis. And what we found is out of 1,000 or so patients that presented to the MRI lab over the course of the last probably 5 or 6 years, that came for evaluation of mitral valve disease. We had about 350 patients or so when we applied these exclusion criteria, and then we stratified those patients into those with mitral valve prolapse versus those without, and it fell out to be about an equal group, 177 with prolapse and 179 without mitral valve prolapse. And we also did is looked at, okay, what is the prevalence of fibrosis in this large cohort of patients? And so the blue group here is a group of patients that's classified as having mitral valve prolapse, and the right group here is those that do not meet criteria for mitral valve prolapse. And what you'll notice is, again, the different types of fibrosis that we found in these patients. One, the most common is the one that I show on the upper left, which is this mid-wall fibrosis in the kind of the infralateral wall. Some patients had, and this doesn't project as well, unfortunately, but some had this kind of patchy fibrosis. Some had RV insertion site fibrosis, and some had evidence of just a subendocardial infarct. So despite the fact that we excluded people that were thought to have coronary disease, some, okay, I guess somebody didn't like those results? Okay. So, and here's what we found is that if you look at the prevalence of fibrosis on a per patient level by segment, 31% of patients in the mitral valve prolapse group actually had evidence of fibrosis by CMR in the basal infralateral wall, 10% in the inferior wall, and 9% in the infraseptum at the base. And then if you look at the mid segment, again, you have about 1 in 20, 5.7% that had hyperenhancement there. Compared again to this control group of those patients without mitral valve prolapse, you can see really the prevalence of fibrosis in this group is very little. Nothing is over 5%, right, in no given segment. So suggesting, in fact, that patients with mitral valve prolapse definitely do have a much higher prevalence of fibrosis than a control group of patients without mitral valve prolapse. The other question then was, is this just secondary to mitral regurgitation? Is this somehow mitral regurgitation that leads to fibrosis in the myocardium? So what we did is we then stratified these patients by severity of MR. So on the left-hand group is those with a regurgitant fraction of less than 10, fraction of 10 to 29, 30 to 49, and then a regurgitant fraction of more than 50%. So essentially the group of patients with mild MR here, moderate MR in the middle, and severe MR on the right. And you can see the blue group is those with prolapse, and the red group is those without prolapse. And you can see that there is an increasing prevalence of fibrosis on a per patient level with increasing severity of MR. But what's interesting is it's much more prevalent in patients with prolapse for any given severity of MR than it is for patients without prolapse. All right? And then what was also interesting was if you looked specifically at those areas of the left ventricle that's adjacent to that posterior papillary muscle, again, focusing on the inferior and infralateral walls, what you see is that the non-MVP patients, really there's almost none of those patients had fibrosis in that location, whereas the patients with MVP, you can see, had, again, an increasing prevalence of location, or increasing prevalence of fibrosis based on the severity of mitral regurgitation. So we then did a multivariable analysis to say, okay, what are the factors that are independent predictors of having fibrosis anywhere in the left ventricle, which is the left-hand side of this graph, or this table. And again, this is kind of a busy table, or specifically in the areas adjacent to the posterior medial pap muscle, which is the right-hand side over here. And what you find is we look at any fibrosis anywhere within the left ventricle, the factors that predicted that were on multivariable analysis was LVEF, mitral regurgitant fraction, but the most significant with an odds ratio of more than 4 was simply having mitral valve prolapse. So that seemed to be the factor that was most strongly associated with having fibrosis within the myocardium. And then if you look at fibrosis within that specific area adjacent to the posterior medial pap muscle, again, the factors are systolic blood pressure, atrial fibrillation, LVEF, but again, very, very strong relationship or association was having mitral valve prolapse present. With really a 50-fold higher rate of having fibrosis in that region if you have mitral valve prolapse versus patients that don't have mitral valve prolapse. Let me skip past this one here. And then the last thing we did is said, okay, let's follow these patients out over time. And unfortunately, that graphic should have come up later. But I think you can see the point here, which is if you look at the incidence of events, and if we look at just arrhythmic events, which is sudden cardiac death, aborted sudden cardiac death, or VT requiring an ICD placement. And again, remember, if you look at the exclusion criteria we had, these are people with normal EF. We excluded everybody with an EF less than 50, everybody with a history of coronary disease, a history of any other factors that could be thought to be associated with a cardiomyopathy. And the annualized event rate for arrhythmic events for patients who have mitral valve prolapse who have fibrosis by CMR was close to 4%, versus patients with MVP and no fibrosis, or the control group of patients without any mitral valve prolapse, where the incidence of arrhythmic events was much lower. And then on the right-hand side here, or the left-hand side, I'm sorry, is a composite of arrhythmic events plus death. And again, you can see for the MVP with SCAR group, the annualized event rate was almost 6%. So again, I think this really suggests that with CMR, we have the ability to find these small areas of fibrosis that really would be hard to identify by any other technique. But that these are somehow uniquely associated with mitral valve prolapse itself, and that this seems to be associated with an increased incidence of adverse outcome. Okay. Yeah, John?
Before we leave that is really fascinating. If you had told me that in the posterior medial location there was more scar with mitral valve prolapse, I'd be prepared to believe that on the basis of some hemodynamic stress in that area because of the prolapse. Or maybe that is causing, that's related to maybe the primary cause of the prolapse, the scarring. But when you show us that this fibrosis is disseminated through the heart, that suggests that maybe there's some primary process that's related to fibrosis, generally speaking, in the ventricle and mitral valve prolapse. There's some common causality.
But if you look at the greatest prevalence, though, is really in the area adjacent to the papillary muscle.
Sure.
Right?
Sure, yeah.
So
But
it's primarily in that kind of inferolateral wall with a little bit extending to the inferior wall.
And that makes sense to me, that, it does raise the question of whether or not there's some primary process responsible for both mitral valve prolapse and fibrosis.
Yes, yes. And so that's actually one of the other things we're looking at as well, which is to look at more global fibrosis. And that's what I'm going to touch on in the second half of this talk. So you're absolutely right, which is I think that there's, there's two things you always have to keep in mind. What we're seeing here, what we're talking about here is regional replacement fibrosis. And then there's also this issue of interstitial fibrosis. And the second half of this talk is going to talk about that. Yep. Yeah, Ash?
No, one of the interesting things, we are looking at least I'm looking at this WHO group 2 pulmonary hypertension and collecting serum samples in patients who are undergoing MitraClip procedures in the cath lab. And at least in patients who have elevated PVR, at least in those patients, there is elevation of PDGF. Now, these are all patients who had MitraClip 2. I don't know how many of them have,
Prolapse versus not prolapse, yeah.
Versus non-prolapse, but I know that PDGF is one of the things which does affect fibrosis. I never looked at the mitral. It's more interested in the.
And that you would expect to be more of a global phenomenon, right? You would expect probably more global fibrosis, and so that's. I don't know if I've got some of those slides in here, but that's actually the second follow-on to this that we're looking at. Which is we're looking at, let me come back to that, because as I'll talk about the other technique that we have. Okay. Any other comments on this? Yeah.
Is there any data as far as progression of the fibrosis, people that go undergo surgery versus don't, or?
Yeah, so that's a good question. We don't know anything about that. I skipped this slide originally in the interest of time, but let me go back to it. This is what's interesting is, if you looked at, this is a patient with mitral valve prolapse pre-op. This is a patient post-surgery. What's interesting is if you look at the papillary muscle, that traction that you seem to see at baseline seems to go away. Yeah. Okay. Now, again, but we don't know. I mean, this is one of the things that we're interested in looking at, is looking at these patients after surgery to see what happens to them. Okay. But at least, certainly I could hypothesize, based, again, on this one anecdote, that maybe by doing surgery, you may alleviate the stress on this papillary muscle, and maybe that could prevent the formation of fibrosis, but nobody knows. It was kind of funny, because when I first started showing these findings to Dr. Lowry, he kind of started laughing, because he said, you know what, that's interesting, because Denton Cooley, he said in the 80s, when mitral valve prolapse, people were more concerned about it, I guess, used to believe in going and operating early on these patients to try to prevent complications. So again, we don't know. Yeah. Carlos?
Yeah, so these patients are mostly bileaflet prolapse, or?
No, so in this cohort here, it was about 25% were bileaflet, and the rest were single leaflet prolapse, and most of them were posterior leaflet.
And there's no effect like on the fibrosis?
So yeah, so we try to look at, does bileaflet prolapse versus posterior versus anterior, is there a difference? We didn't find one in our cohort. And again, this may be an underpower issue. It's about 180 patients that we had total, of which about a third had fibrosis. So that's something I think there's room for further study on that, is to say, is there a differential difference between the extent or severity of prolapse? Yep. Yeah.
Is there an advantage of doing late gadolinium enhancement as opposed to T1 mapping
Yeah, so we'll get to that because that's going to be the second half of this talk. So you guys are actually setting up very nicely, which is the idea that, you know, if we look at delayed enhancement, what I've showed you up till now is this is a technique that allows us to identify replacement fibrosis. And the way that this works, for those of you that haven't rotated through the MRI lab, is you basically have to identify what we call a null point, a normal reference area. So you identify an area of normal myocardium, and you adjust a parameter such that you image at that time point when normal myocardium gets to the 0 point. Okay, so the way this technique works is you apply an inversion pulse, and then you allow protons to recover. If there's more gadolinium, you get more rapid recovery. And so the idea is you want to apply the inversion pulse and then do your imaging at the point at which normal myocardium has gotten to 0. And then areas where there's fibrosis, where there's increased gadolinium, will show high signal. Now, with this technique, you know, it's all really dependent on when I pick my quote null point. Because if I pick a null point that's higher, longer, then you'll notice although the area in this case of the infarct is still bright, normal myocardium actually is not black. It's a little bit grayish in appearance, right? And on the flip side, if I pick a null point that's too short, I could actually null the infarction, right? Because I could actually make the infarct look black here, which has faster T1 recovery. But notice I picked a point way over here where the infarct curve is at 0, and normal myocardium in this case actually is below 0. But again, this is a technique that is an absolute value reconstruction. So whether the magnetization is positive or negative, it will show signal, right? So I think that what you're getting to is that this allows the ability to look for regional variation. But what we know is that fibrosis doesn't only occur as regional or as replacement fibrosis, but you can also get this interstitial fibrosis, which is much more widely diffused, which may be much more uniform throughout the myocardium. And the question is, for that, is there a CMR technique to be able to identify that? And so let me skip past this here. Let's get to the T1 mapping techniques, which actually allow you to try to identify the presence of expansion of the extracellular volume, or essentially what we think of as is associated with the presence of interstitial fibrosis, which is much more diffuse. And so let's go to here. So the way this technique works, so this is much more of a quantitative mapping technique. So whereas the late gadolinium enhancement is a relative technique, this is a technique now, and again, part of it is that this was only possible in the last few years as there's been kind of further advancements in the imaging techniques, further speed, where you can actually, when you apply that inversion pulse, you don't just wait to get one image at a certain time interval. You actually can acquire a series of images at differing time intervals after you apply the inversion pulse. So you can actually map the rate of recovery within any given pixel. All right? And this allows you to identify what the T1 value is within any given part of the myocardium. So this is able to do a pixel by pixel map of T1 values within the myocardium. And the principle that this applies by, or that this works on, is the idea, and again, it goes back again to the kinetics of gadolinium, which is gadolinium is going to distribute wherever there's more extracellular space, you get more gadolinium. So the distribution of gadolinium is related to the amount of extracellular space. So again, in the acute MI, in the chronic MI, there's an extensive amount of extracellular space, and therefore a lot of gadolinium. And so with this technique, though, what you're doing is you're taking it one step further, and you're actually saying, okay, I can map what the T1 of myocardium is, and I can map or determine what the T1 of the blood pool is. And then I'm going to give gadolinium. I'm going to wait 10 or 15 minutes. And then I'm going to remap again what's the T1 of the blood pool and what's the T1 of the myocardium. Now, what does that tell me? Well, again, if we know that the change in signal is going to be related to the change in T1. So therefore, for the blood pool, I know that if whatever my T1 is here and whatever my T1 value is here, the difference there is directly related to the amount of gadolinium that's present. And we know that's related to the amount of extracellular space. Now, is there a way for me to determine how much extracellular space there is within the blood pool? Well, actually, if we just take 1 minus hematocrit, because we know that within the blood, primarily it's hematocrit and extracellular space. So that's what we do is we measure the hematocrit. So we've now figured out a way to normalize, because we know now what it is within the blood. And then what we do is we say, okay, let's look at what is the change in T1 value of the myocardium before contrast and after contrast. And then just using that ratio, we can actually determine what is the extracellular volume fraction within the myocardium itself. So that's a technique by which this works. Okay? And then, obviously, what I'm going to try to do is go through quickly some of the background literature or some of the background studies that have been done. And again, most of these are relatively small studies. This was one study where they looked at a series of patients that they performed biopsies on. So on the left-hand side is a group of patients with aortic stenosis. And again, they underwent the CMR technique to determine extracellular volume fraction, which is on the x-axis. And then by biopsy at the time of surgery for aortic valve replacement, they looked at the collagen volume fraction in the septum. And you can see there seems to be a reasonably linear relationship between the extracellular volume fraction by CMR and collagen volume fraction by histopathology. And then they also looked at a group of patients that underwent surgery for hypertrophic cardiomyopathy. And again, these are small numbers, but you see kind of a similar relationship. And then lastly, this is when they combine both groups together. And again, you see that there seems to be a regression or relationship between CMR-derived markers of extracellular volume and histologic measures. This was another study looking both at humans and at mice. And in this study, again, they were able to demonstrate in humans a couple of findings. One is that the extracellular volume actually seemed to increase with increased age, and that there's some relationship between extracellular volume and left ventricular mass. And then when they looked at mice, the juvenile mice as well as age mice, what they found again was there seemed to be this relationship in this small study between the percent myocardial fibrosis by histology and the extracellular volume fraction, again, by CMR using this technique. And then this was just another study looking at aortic stenosis patients, and again, showing a similar relationship at the time of surgery. They did biopsies in the ventricular septum. And then lastly, this was a study looking at heart transplant recipients that were undergoing biopsies. And they found, in fact, the mean time here was about 29 days after the heart transplant, that there's a relationship again between extracellular volume fraction by CMR and the histologic volume, at the time of histology. So one of the things we wanted to do was to say, okay, let's look at, does this offer prognostic value? So we've got a technique which we think allows us to identify situations where there's an expansion of extracellular volume, which we think is associated with increased deposition of interstitial fibrosis. And the question now is this a marker of risk? So we looked at a large cohort of patients that had gone through our lab that we had been performing this technique in, and then applied certain exclusion criteria such as patients with cardiac tumors or infiltrative processes, or patients that we didn't have access to a hematocrit within a reasonable time window. And then we looked at outcomes in these patients. And again, the outcome here was a composite of all-cause death as well as cardiac hospitalization. And then the secondary outcome was all-cause death or cardiac hospitalization alone. And here's what the characteristics of this cohort are. It's a mean age of 58. A little over half were men, with about 3/4 were Caucasian, about 14% were black. 2/3 or so had hypertension, about a half had dyslipidemia, and about a fifth of these patients had diabetes. And these are the baseline blood pressure, heart rate, height and weight data here. And these are the baseline medications that these patients were on. And the follow-up here was about a year. We've done now an additional round of follow-up, and we're just doing the analysis on that, which would bring our follow-up closer to probably 18 to 24 months. And at this time point, there were 282 composite events with 112 deaths and 195 cardiac hospitalizations. And here's what the results look like, which is if we stratify patients based on those who have a normal extracellular volume fraction, and again, this is derived based on a cohort of normal volunteers that we imaged, versus those who have an elevated extracellular volume fraction. So again, what we think is a marker of increased interstitial fibrosis within the myocardium. You can see there's a significant difference in prognosis between these two groups of patients. And then, furthermore, and most of this work, Eric's been working on. This is his AHA grant for the last year that he's been working on. He also looked at, if we look at this extracellular volume fraction as a continuous variable, and actually plot out the hazard ratio, what's interesting is you'll notice that there is kind of this linear relationship that as you have an increase in extracellular volume, there seems to be associated with a worse outcome. And it crosses the hazard ratio 1 probably around 25 or so. And this, again, is for the composite endpoint. Now, after you do adjustment, because one of the things, obviously, is the question is, are there differences in baseline characteristics? So when you adjust, and again, when you have a large cohort like this, you're able to do multiple adjustments. So in this analysis here, it's adjusted for age, sex, race, inpatient status, scanner type, hypertension, diabetes, prior MI, body mass index, blood pressure, LVEF, LV mass, as well as replacement fibrosis. Because the other question is there incremental value of this on top of being able to just do replacement fibrosis assessment by the late gadolinium enhancement technique, which we've had now for several years. And again, you can see that there seems to be an incremental predictive value here of this over and above what you get with just replacement fibrosis alone. This now is looking at just cardiac hospitalizations. And again, you can see a stratification based on those with normal ECV versus those with high ECV. Again, this is looking at it as a continuous variable unadjusted and looking at it as a continuous variable adjusted. And it looks like, again, that there's some level at which, as it increases, you begin to have an increased likelihood of events, but then at some point it plateaus out. And that may make sense because if you have 40% or 35% fibrosis within the myocardium, again, interstitial fibrosis, there may be some threshold at which you're not going to see further bad outcome because you may already have a very bad outcome to begin with. And then this is looking just at mortality, just at a hard endpoint alone. Again, showing you a similar finding, which is there's a stratification based on the presence or based on an increase in extracellular volume fraction. And Eric's kind of in the final stages of putting this all together as a manuscript. And I think kind of the take-home message here is that this ability to identify expansion of the extracellular matrix beyond what we can see with just regular replacement fibrosis by late gadolinium enhancement may be associated or may be a marker of worse outcome in these patients. And then, lastly, I want to just touch on a couple of other projects that we have ongoing right now, which are trying to apply some of these principles that we have or some of these techniques that we have to a variety of different cohorts of patients. So one is this study called the MITRA-REVERSE study. So this actually is a multi-center study that we've managed to get funding from Abbott as well as one of the contrast manufacturers to look at cardiac remodeling and fibrosis in MitraClip patients. So these are, and so we picked 4 sites for this study. And again, we're looking at patients that are getting MitraClip implantation, patients that are high risk for mitral valve surgery, that have primary mitral regurgitation. And I'll show you a couple of examples. So here's a patient who, on the top here, if we look at his left ventricle, you can see the LV is dilated. LV end-diastolic volume is 256. And he has severe MR, regurgitation fraction of 56%, and regurgent volume of 64%. This person, after placement of the MitraClip, and you'll notice we see a little bit of artifact from the clip here at the very basal slices within the LV. But again, if you look at this person, look at the size of their heart before, look at the size of their heart after. The LV end-diastolic volume is shrunk down now to 197 cc's, and their regurgent volume decreased quite substantially from 64 down to 11, and regurgent fraction went down to 13%. So here's an example of significant reduction in MR after MitraClip placement and significant reverse remodeling with shrinkage of the ventricle. Compare that to this other case. Let's see if this plays for us. Okay. Where you see a patient who's got a dilated ventricle, LV end diastolic of 208 cc's, but really not much in the way of a reduction in LV end diastolic volume after clip. And this person, you'll notice the mitral regurg severity really didn't decrease that much. The regurgent fraction went from 38% down to 31%. So this is an example of somebody who didn't really reverse or model that much, but also there really wasn't that much of a reduction in MR severity. Now, there's a few things that we're trying to kind of get a better understanding of, and this is the study design for this study. So we're looking at patients that are scheduled to get a MitraClip. They all undergo a baseline CMR as well as an echo, as well as fibrosis assessment by a couple of different methodologies. One is to look at fibrosis within the papillary muscles itself, replacement fibrosis, and the other is to look at the extracellular volume fraction, which we think is a marker, again, of interstitial fibrosis. And then these patients then, after their clip, will undergo a follow-up CMR within the first week to look at acute remodeling, as well as a follow-up CMR at about 6 months to look at chronic remodeling that occurs. And then we'll also do clinical follow-up on these patients as well. So this is, again, we're just getting started with this study. This is a project which we anticipate will run for about 2 years or so with initial enrollment. And so again, with this study, a couple of things we're trying to look at. One is obviously is interstitial fibrosis manifested by extracellular volume fraction, but also we've got this newer technique, which is a dark blood delayed enhancement, because one of the challenges with the standard delayed enhancement is it can be hard to identify hyperenhancement within the cavity because you've got high signal within the blood pool itself, right? So this is an example of a patient who, if I just did the standard late gadolinium enhancement technique, I really wouldn't be impressed to say, yes, there's infarction of the papillary muscle. But when we do this dark blood technique where we actually make the cavity appear black, you can very nicely appreciate that this person, in fact, has infarction in both anterolateral and posterior medial papillary muscle. And so one of the questions is, does this somehow modulate your success of procedure or your remodeling that occurs? And then the other questions are going to be with this study is, does the amount of interstitial fibrosis that you have based on extracellular volume fraction at baseline, does that modulate the amount of reverse remodeling that you're going to see? So for any given reduction in MR, does it modulate the ability of your ventricle to be able to remodel after you reduce the mitral regurgitation? So these are some of the objectives of this study that are shown here. So let me pause there. I'm a little bit over time. And this is just kind of a overview flavor of some of the things that we're looking at from the standpoint of fibrosis, both looking at replacement fibrosis via the late gadolinium enhancement technique, which again has been around now for about 15 years, as well as this newer technique of looking at extracellular volume fraction. And this technique really has only been around for the last probably 4 or 5 years. Okay? Any comments or questions? Or, yep, John?
Great technology, wonderful presentation. Have you tried to link this to small animal imaging facility? Are you working with them?
Yeah, so we have not done a lot. The challenge is that with the, so you know, there was a 9 Tesla scanner in Baylor, and we were working with GERD. The problem is the technique that we use for interstitial fibrosis assessment for extracellular volume fraction, that technique isn't really available on on most of these small, the 9 Tesla scanners for small animal imaging. So really, it's hard to do this technique with small animals at this point. Now, again, this was a few years ago when we looked at it, and I don't know if there's been further evolution in that. Most of the sites that had done some of these small animal studies, they basically had a physicist on site that could do pulse sequence development, that would actually kind of program these pulse sequences. So that's been one of the challenges, yeah. Okay, yeah, Dale?
Yeah, with this T1 sequencing, in terms of conditions like diastolic dysfunction, if where there may be a progression of fibrosis,
Yeah.
could it be used to monitor the progression of
Right,
that?
so that's a very good point. Because if we think about it, when we measure diastolic dysfunction, what we're measuring is probably kind of the end manifestations of fibrosis. With CMR, you actually have the ability to image directly or indirectly what's expansion of the extracellular space. One of the things that we have been looking at, one of our postdocs has been working on, is looking at our diabetic cohort of patients to say, okay, amongst these diabetic patients, those who have expansion of the extracellular volume, are those patients at a higher risk of adverse events? And interestingly, what we're finding is, in fact, that there is a link between, in the diabetic group, of increased extracellular volume fraction and a higher likelihood of adverse events. Now, the next question is, can you modulate that and see a reduction in that, or reversal of that? That's one of the things we don't know yet. I mean, that would be very interesting to do a study, to look at a cohort of patients that are getting some therapy, where you image them at baseline, and then you try to see if you actually see a reduction in this over time.
Yeah, but I think the most fruitful group here, and I think you will get money from the American Heart Program, because you have a tool that is still very hot, but not everybody has put their hands on it. And it's able to give you something that before this tool was available, you could only get by biopsy. So, to me, the most fruitful group is hypertensives. We have shown in hypertrophic cardiomyopathy, we have shown it here, and others have shown it with valvular AS, that if you reduce afterload by either relieving an obstruction in hypertrophic cardiomyopathy or changing a valve in hypertension, that serial biopsies demonstrate significant reduction in interstitial fibrosis. So a hypothesis would be that you take a group of fresh hypertensive that has some echo findings of LVH, diastolic dysfunction, and whatnot. You get a baseline extracellular volume, and then you follow them as the blood pressure gets controlled to show regression of
reduction.
And that, I may tell you, that would be a big, big finding because of hypertension being such an important disease. And I suspect, well written, we could get an American Heart Association grant for that. To me, that is big dollars. This stuff with MVP is terrific. It's exciting. But the big money is where the big, big problem exists, which is hypertensive, elderly. I think what you're doing with diabetes, all that link of diastolic dysfunction, hypertension, that could be very fruitful.
Yeah, no, that's a very good comment.
I think we should try to get together and work on that.
Good. Any other comments, questions from the audience? Okay. All right. Well, thank you for your attention.